Naushin and Sakita to come here.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रवेष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्र परित्रात्रे गुरुपाखण्ड खण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. Dr. S.K. Mishra, HOD Community Medicine from JSL Medical College. Dr. Prasanna Josla from Lady Harding Medical College. Dr. Krishna Babu Garu, our organizer. Today's speaker, Dr. Sanjeev V. Thomas, onto the stage. I invite the chairpersons to come on to the memorial photo, all of you. Please honor Dr. Prabir Das is invited to the stage. I invite Dr. Prasanna Josla to.
I don't say it is a pleasure, but it's very heartwarming for me to introduce somebody like Dr. KN Rao. Initially, I started putting it in the Google to see who is Dr. KN Rao. I accept my ignorance over here. when I saw there were two KN RAO and both of them are very eminent. And I had to look into the full form of K and N to actually, because there were two KN RAO and both of them more or less were born at around the same time, around the same place, and have the same name other than only the surname is different. So I take this opportunity to introduce, to say very little about, the information is only available in the IPHA online. Nowhere else. I put all the combinations as a DG, XDG, everything into the Google, but still the information came on to be only IPHA online information. So Dr. KN RAO, who is an MD, and he is Dr. Kamaraju Narasimha Rao. Very interesting part is he was born 31st of January and he died on 5th of February, which the days actually coincide with the conference of IPHA here. So it was, I felt very interesting over here. He is from Guntur district, Andhra Pradesh. He did his MBBS in 1930 and became a fellow of Royal College of Physicians in UK. And he joined Indian Medical Services in the military wing in 1935. Also was a prisoner in war in Singapore from 1942 to 45, the period of World War. He was 1951 as professor of tuberculosis in Stanley Medical College, Madras, where his ascent into the other posts in India started. He was advisor to Government of India on tuberculosis. He was Director of Health Services of Andhra Pradesh between 51 to 63, a long duration. From there, his ascent towards the additional Director General Health Services, Government of India, and Director General of Health Services between 63 and 68. He was President of Tuberculosis Association of India as well. But a lot of, he was both an administrator and an eminent medical scientist. Professionally, he was associated with a lot of organizations, both national and international. He is recipient of Dr. PN Raju's Oration Award and Saurabh Oration Award from Indian Association of Physicians, BC Das Gupta Oration Award by the IPHA, and he was president of IPHA during 1966. He remained chairperson of expert committee of to WHO on tuberculosis. Also, he was on the executive board in WHO for some time between 67 to 68. He was first president of World Federation of Public Health Association. He was consultant for medical education, both for World Health Organization and PHAO of Latin America. He was honored by LLD by Sri Venkateshwara University, Andhra, Tirupati, and he was Executive Director, National Academy of Medical Sciences. He was authority in family planning and population control and advisor to the Government of India. He acted as Vice Chancellor of Dr. NTR University Medical Sciences, Vijayawada, and he is an accredited leader of medical profession in India and abroad. So with this, I would invite the speaker for today, who would enlighten us on an area where it's interesting for community medicine specialties. Sir, Doctor?
Dr. S.K. Mishra.
Fine, carry on. Yeah.
Thank you, madam. Please. Thank you, madam. I invite Dr. S.K. Mishra to introduce the speaker, today's speaker, Dr. Sanjay V. Thomas, to the.
Good morning, all of you. It is my privilege to introduce an eminent person to the august gathering. He is none other than Dr. Sanjay V. Thomas. He is the professor of neurology and he is the head of R. Madhavan Nair Center for Comprehensive Epilepsy Care. His journey to health services started with his MBBS career, which he has completed from TD Medical College, LAP, Kerala, in the year 1979, followed by MD in General Medicine from uh, Kerala Medical College, Trivandrum, in the year 1984. Subsequently, he has done DNB in internal medicine in April 1985 and DM in neurology in 1998. His quest of knowledge has not ended there. He has to sharpen his skill. He has done additional trainings like advanced training in epileptology at NIH Bethesda, USA. He has also done epilepsy surgery training in University of Umeå, Sweden. He has done training in the magnetoencephalography University in Texas, Houston. He is having a long list of fellowships, awards, and distinctions to his credit. It all started with during his MBBS career itself. He has earned SS Rao Gold Medal for the best medical student in the year 1979. And few of other fellowships and awards are Tadakero Award for the best paper presentation and Asia Ocean Epilepsy Congress in Bangkok, Thailand. Bimla Birani Award. FIAN, he was Fellowship of Indian Academy of Neurology, Fellowship of Indian National Academy of Medical Sciences, then Fellow of American Neurological Association. In addition to his present responsibility, he is also has taken other additional administrative responsibility. He is also Associate Dean and is from June to 2014 to 2015. And he is still continuing as a head of Kerala Registry of Epilepsy and Pregnancies from since 1998 onwards. He has also contributed in leadership and organization skills. He is the president of Indian Academy of Neurology, and he is also the president of Indian Epilepsy Society in 2017. He is the editor of Annals of Indian Academy of Neurology from 2006 to 2011. He has also actively involved in various international organizations' contributions. He has contributed in International Registry for Antileptic Drug and Pregnancy. He was a special invitee in World Health Organization's meeting on global consensus of preconception care in Geneva. He was member of ILAE Task Force for Epilepsy Treatment Guidelines. He was also core member of ILAE Commission on Medical Therapy and International League Against Epilepsy. He has many prestigious orations delivered across the country and abroad. Few of them are Baldev Singh oration, K.S. Mani oration, B.C. Bansal oration, Professor K. Srinivasan Endowment Lecture at Trichy, and oration at the Bombay Neurological Associations.
had struggled in what is the term consciousness for in the darkness to find cause. It is quite common to start in the early childhood, but much more common for people in the elderly group to develop epilepsy. At the fag end of the, if you look at the yellow and I think orange and the red bars, you can see that the incidence in the older age group has increased in the recent past. This is data from the Mayo Clinic. What is the prevalence of epilepsy? By and large, it is considered to be around 5 per 1,000, and in developed countries as well as in the underdeveloped countries. The incidence in the West is 50 per 100,000, and the incidence in the low middle income countries is 80 per 100,000. So if we have such a higher incidence and lower prevalence, what is happening? People are dying. That is why prevalence doesn't go up. So the developing countries are experiencing considerable increase in the mortality, which is submerging it. So people, that is a hidden disability, which is not really recognized in the professional field or in the administrative level. And what about the DALI in various countries? Africa tops, but Southeast Asia is second highest. The prevalence, along with that, if you take the treatment gap, a large number of people with epilepsy are not getting treated in India. The treatment gap is estimated to be 75 That is really bad. Only 1/4 are getting treatment, 3/4 are not receiving any treatment. The public health system of our country is unable to reach these people and provide them appropriate treatment. These are issues to be addressed. We have looked at the mortality of epilepsy in our patients. These are hospital data, not community-based data. 10-year follow-up of a cohort of 558 people. We had 25 deaths. There were no deaths in people who had no seizures. People, if the seizures are controlled, none of them died. But if the seizures are not controlled, they died. So obviously, treating epilepsy reduces the mortality and improves the DALI. These are the factors which may be associated with it. What are the causes of death? In India, we don't have that much of clinical autopsies. We had to do verbal autopsy also in situations where clinical autopsy data were not available. It is unusual, not unusual to see brain tumor or status epilepticus patients dying, but 15% died of suicide. 20% died in accidents. So altogether, 2/3 are over. What about the 1/3? 1/3 is sudden death, unexpected death in epilepsy for known medical causes. These are boys and girls who sit and have their breakfast, go back to their room, and 1 hour later, the mom or dad finds them dead. This is what is called sudden unexpected death in epilepsy. 1/3 of the mortality in our patients was sudden unexpected death. I'm certain that even the clinicians are not familiar with this term. That means people are not aware of the kind of problems people with epilepsy experience. There are considerable social issues that I would like to touch upon, which have a bearing on their disability. Stigma is one of the main problems. Stigma starts with a trait, and then it goes on to become a stereotype, and finally a loss of status, which are the grades and steps by which people are doing. A person with epilepsy, what trait is there? What is there externally visible? A person with Hansen's disease may have hands or eyes or face which may show that they have Hansen's disease. But epilepsy people with epilepsy do not have that. Then what is this trait? The trait most often is that they are taking medicines. Or that girl who takes the medicine. Or the father comes and buys the medicine for this girl. I know this is a problem. So this is where it starts. And the stereotype comes after that, and then loss of. There are two types of stigma. One is the enacted stigma. That means they are actually experiencing. A person thrown out of job because he has epilepsy, it's an enacted stigma. A person goes for an interview and is declined, refused a job because he has epilepsy, it is enacted. A teacher is calling the parents to tell that take your child home, bring him back only after the seizures are controlled. Don't send him to the school. Enacted stigma. They are unable to continue. So this is not uncommon. But what is much more than that is the perceived stigma. Anticipating these eventualities, people withdraw. They feel that, if I go there, I am unlikely to be welcome. I don't have to go. If I go for this marriage, people may not enjoy or appreciate it. Let me not go. So this is perceived stigma. This is what majority of the people with epilepsy are experiencing. And is there any study which has quantified the stigma and its repercussions on the life of people with epilepsy from our country? Very little studies are there. Stigma may be at the level of the individual, the sphere and domain may be at the level of the individual. It may be at the social relationships or at larger level with the community. Each one actually needs a larger elaboration, but for sake of time, I'm not going through that. And study into any of the stigma-related issues to address these three levels and tiers of stigma. At the level of the natal family, there are considerable overprotection and the family approach. I want to point out that in our study, we found that if the the main person in the family, mostly the father, takes a very positive attitude, the rest of the family falls in line. So the people of influence, people who matter, if they change their attitude, it falls. The same thing can happen in the society too. In the marital family, they have considerable problems, marriage and dowry harassment, neglect, abuse, and abdication of female reproductive rights. Many women with epilepsy have to undergo sterilization procedure, not of their choice, but because the family do not want them to have children. These are not revealed often. Only when we really spend a little time with them, talk to them, only these kind of problems are coming up. Clinicians generally don't ask these questions. They only ask how many seizures you had in the last 1 month and what medicine did you take or not take. This is what often is asked. So there are social impacts of epilepsy which need to be looked at. Participation, educational restriction, employment, these are all areas in which they. And stigma is where the most important effect of stigma is with relation to marriage. We often tell you are not marrying epilepsy. A woman or a prospective boy comes to us and talk to us, or we tell them, we are not marrying epilepsy, you are marrying a person who also has epilepsy. She may have virtues, she may have qualifications, she may have jobs which are on the positive side. On the negative side, she has epilepsy. So look at it in a balanced manner than looking at it only from one side. There are biological issues for women with epilepsy. There are social issues which, as I was elaborating, are much more than the biological issues. This was a study which was carried out with a lot of in-depth interviews as well as with several formatted and structured questionnaires and without questionnaires. Over the last, I would say about 15, 20 years, we have been doing bits and pieces of this study at various stages. And one of these is the data samples I have just shown. One of the girls told me that epilepsy is easy to conceal and difficult to reveal. I think that is a very, very meaningful sentence. It is easy to conceal, difficult to reveal. And this girl is no ordinary girl. She had a couple of seizures, she got married and got divorced in a week's time. She went on to complete her studies. She did her sociology master's from Australia. She has done a PhD in anthropology. She has done a public health degree from Harvard, and she is in US as a professor. And she is my patient too. And when she was in India, she had been working on a stigma and social issues of this being. We had together worked also. So I have appreciated her positive attitude and the way she has worked. I should credit her for much of the data that I am talking today. Disclosure is another major issue. Whom to disclose, what to disclose, and when to disclose. Disclosure in the school or the educational environment, disclosure at the time of marriage, employment, and in casual social interactions. At what point do we need to disclose, when to disclose, and how to disclose is a big issue. Strategies of disclosure. How do people disclose or choose not to disclose? There are issues. Directly, some people have disclosed. Some people have waited until the discussions went to a more final stage when they wanted to disclose it. At forced disclosures, so somebody gets a seizure in the bus station. There is no question of her concealing it. It is automatically disclosed. Indirect information. Somebody says, okay, you meet my doctor, he will disclose what is to be told to you. So these are all issues. What is the appropriate way? What is the role of the physician in this matter? What is the role of the family in this matter? Individuals' rights and privacies. These are all issues to be kept in mind when we talk about disclosure in epilepsy. What are the fallout of forced disclosures. There are several fallout which can be quite disastrous. Now let me move to another area of the disability, the economic disability of epilepsy, which can be dealt with in a very different ways from the community perspective, individual's perspective, as well as from the more from the administrator's viewpoint too. This was a paper which we did about almost 20 years back, economic burden of epilepsy in India. This is the national study, 6 center where different 6 states were participating in it. A summary of it, I will just say that, economic burden is generally cost of epilepsy or any disease is considered in direct cost and indirect cost. I think you are all familiar with all those terms. I don't have to go into it. Indirect cost is the one which is related to loss of work and other things. Direct cost is related to medical expenditure. The cost of epilepsy it was 13.8 lakhs per 1,000 people, treating people, was the cost that we calculated. Unfortunately, this is the only data available on the cost of epilepsy from any developing country. And WHO often quotes this as the data for developing countries. And if this was in 1999 that the data was collected. If you project it for today, it comes to 59.8 lakhs for 1,000 people. Now, this is what I want to say. This is the data. If people are treated like this, the way they are at that point of time being treated. Now, direct cost is only around 25%. Indirect cost, which is largely because of poor control of seizure, is around 75%. Today, if you treat them better with more advanced medications or surgery, the seizure burden will come down. The cost of medicines and surgery will increase. You can see that the direct cost has increased and the indirect cost has come down. The net effect is that the total cost of epilepsy had come down by 1/3. So what does that mean? If the country chooses to invest in treatment, the country is actually saving money. So it's a good investment to invest in epilepsy care so that the total cost comes down. In this country today, we have only a handful of centers which are providing surgery for epilepsy. When 30% of people with epilepsy require surgery. Today, we are using medications which are, and that also 75% are not receiving treatment, and that is offering only 50% people to control seizures. With better treatment, this control can be increased to 70%. So with these things, it will come down and you can reduce the cost of treatment. The treatment gap is another area. Why people are not getting treated? There is a strong gender bias in the treatment. Women with epilepsy are not getting treated as much as men with epilepsy, particularly in the age group of 30 to 50 years, very few people are getting treated. So targeted attempts are required to provide treatment. The determinants are economic and social factors are there. The quality of life is another major issue. When we do all these things, how does it really matter? Physicians look at the seizures and the adverse effects, which is only a small part of the epilepsy problem. The large problem which the patients are experiencing are not only the control of seizure, but how they live, educate, employed, and leisure activities. We had tried to look at the quality of life of people with epilepsy and how that is modified by various factors. And what we find that, when patients are treated in the community without advanced care, majority of them are on some drugs, or about 1/5 of them are in that study was not on any drug, and they had very frequent seizures. Now, when they came to Sri Chitra, we offered, hopefully we claimed that we offered a better care, and more patients were on treatment. nobody was not on treatment, and the seizure control was better. Very small fraction was continuing to have seizure. More than 50-60% were seizure free. So this is the effect of the seizure. Now this group, if you look at the quality of life, the most important things were the frequent seizures and the polytherapy which were obtained. And the last part of my talk is about the disability which can be measured. We know that Stephen Hawking had motor neuron disease and he recently died. And how did his disease, which is a fatal disease, influence his performance? He managed to overcome those disabilities and live a successful, productive life and contribute to the science. Disability is an umbrella term, and impairment is the physical problems which may be either structural or a functional impairment, or it may be an activity limitation like mobility limitation, limitations in thinking, communicating. These are all activity limitations. And lastly, it leads to a participation problem. Someone who has a blindness may not be able to go and attend to the marriage because he can't move. Another person with a hemiplegia may not be able to go because he is locomotor difficulty. And a person with epilepsy may choose not to go to marriage because of the stigma. Ultimate result is that all three people did not go for the marriage. Ultimately, all three people failed to participate in a function which they were expected to do. The disability quantified for all the three people, the one who had blindness, the one who had hemiplegia, and the man with the epilepsy were the same. They failed to attend to the problem. So these are issues. Some of these disability may be features related to the body as the blindness or hemiplegia. Another thing may be disability attributed to the society, which is the enacted or acted perceived stigma. So this is what is essentially happening. We try to look at, can we capture this disability of people with epilepsy using some sort of an instrument which can be used reproducible with a show reproducibility. We used a selected disability assessment schedule version 2 of the WHO, which has a domain for understanding in communication, mobility, self-care, getting along, ADLs, and social participation. And this is a generic one which can be used for any purpose. And when we use this questionnaire, what we found is that most of them had very minimal disability. And around 15%, if you put a cutoff of around 12 or 15, have significant disability. The WHO-2 studies in the population have shown that in any community, around 15% will have severe disability. So we use that 15% as the cutoff. And if in any community 15% are affected, I think in epilepsy also should be minimum 15% affected. So we put a cutoff of 15. And these were the domains in which various disabilities were affected. Understanding was significantly affected. Last one, the social participation was considerably affected. ADL was activities of daily living were not much affected. And getting along with the communication, people interactions were not so much affected. But most of it was in social participation that was affected, and in communication and understanding. These are the main areas in which people with epilepsy have problems. We try to correlate this with the existing things like the quality of life, WHO well-being index, and the IQ of the people. All of them showed a good linear correlation with the DAS2 scores. And these are the data for that. Finally, 36 questions is too big, so we decided to choose the 12-question mini version and add 3 more epilepsy-specific questions which are related to the seizure control, use of medications, and make a 15-item questionnaire to measure the disability. And we found that this is a quite handy instrument to capture the disability of epilepsy. And these are the data for and the statistics for these patients. So we hope that one day it will be possible for a clinician to measure the disability and use the instrument to tailor the treatment and also promote his social adjustment and maybe the society will choose, or government administrators will choose to give some benefits to people with a certain degree of disability. And epilepsy-related disability at the moment is not listed in the disability list, and they deserve to be on that list, and they can be also included. So these are some of the aspects. From this talk, I would have, as I was trying to focus more on the hidden disabilities. We know that the disability of epilepsy is like an iceberg. Only around 10% is visible. 90% of it is all submerged, and we need to delve into that. As I was mentioning, what the eyes see is only what the mind knows. So first of all, a change has to happen in our mind. Thank you very much for the patient listening.
Clinicians moving into the community aspects of patient management, that really encourages us. And sir, I just want to, after what you said, outreach. And also like epilepsy all the time come to a tertiary, or very rarely it goes into a risk management of with epilepsy into, or pediatricians where the growth and development of the children are monitored. But where do we actually catch the disability part of epilepsy? Primary or a neurology into the outreach, or referral? That is, I would like you to.
Thank you very much for the question. I think there are two aspects to it. One is the prevention of disability, which should start very early. That is probably starting with the prevention of epilepsy to begin with. If that is not possible, at least preventing the disability or minimizing the disability by early interventions. What are the interventions? Medical interventions, social interventions, economic interventions that will reduce the disability is the question. I think we need to look at this and then develop strategies to like that. The second aspect is, someone who has already developed disability, how do we help them to overcome this problem? These are the last part of it. People have already developed our issues, and how do we take care of them and help them? And my talk, I was trying to go through several facets of it in a very, very superficial manner, and we have to probably go into greater depth. For the incidence, if it is increased in India or in other countries, why is it increased? Bad obstetric care, early infections in the childhood, febrile seizures, neurocysticercosis, and all the infections, head trauma. In our country, head trauma is so common, and we have not been able to reduce it. Rather, it is increasing. So these are all related issues which will help us in reducing the epilepsy as well as reduce the disability from that.
Thank you, sir, for your nice deliberation. And as rightly pointed out by you, we know epilepsy has a great deal on the great effect on the society, particularly as it comes to stigma. And we have addressed so many diseases like leprosy and HIV. We are fighting with them for stigma. But this is one thing which I personally feel is neglected a lot, epilepsy, because we don't talk much about it. As basically it is it's not a, I mean, openly we are not coming out to fight with the stigma aspect of it. So that is one thing which you have highlighted, sir. Thank you for that.
Thank you, Dr. Thomas. First, I should thank the IBH headquarters for giving the organizing committee to choose a person for Major KN RAO's oration, and I think our selection has definitely made a difference to this conference. You have enhanced our conference. And so for me, the disability and assessment of epilepsy goes back almost 15 years back. If you go to Andhra Medical College, where we had a neurologist, Dr. K.B. Lu, who was doing a study. And at that point of time, we thought that this subject would become a public health program. Somehow in the last 15 years, it failed to become a national health program. Thank you very much for highlighting the hidden burden of disability in epilepsy. Definitely it helps. Thank you.
Thank you, Dr. Sanjeev, for the elaborate session. I call upon Dr. Sangamitra Ghosh, Secretary General, to honor our speaker, and also Dr. Karunamurthy onto the stage to honor our chairpersons. Madam, please come forward. Come here. పక్కన నిల్చోండి. Dr. S.K. Mishra, honor our chairpersons, Dr. Sangamitra Ghosh. Please honor our chairpersons. Dr. Prasanna Joshila. Dr. G. Krishna Babu. All please come forward. Please come forward. Madam, please come forward for the photo. Sir, please. అడ్డంగా నుంచుంటారేంటి సార్? Thank you.